Both of our presenters right at the end, so save those questions.
Good morning, everyone. I am, as Johnny has said, a GP partner at Compass House Surgery in Brixham in South Devon, a small coastal fishing town, and I'm Clinical Accountable Officer of South Devon and Torbay Clinical Commissioning Group. I wonder if you can imagine a scene where senior clinical leaders across the community, hospital, are together enthusiastically discussing with managers and local authority representatives, 24/7 working, the advances in robotic surgery, and a single clinical record for all. Could this be the future of clinical commissioning? I'm going to talk to you today about patient-centred joined-up care. Just must make sure I don't stand in front of it. The aim of my presentation is to give you an understanding of how we are delivering patient-centred joined-up care in our local healthcare system. I've tried to keep the presentation to 15 minutes, but if anyone wants further details of anything I talk about, any of the clinical projects, then please do not hesitate to email me. I've grouped the presentation into 5 key themes. What area does South Devon and Torbay CCG cover, and what is its demographic needs? What is our vision? How do we intend to implement our vision? What clinical examples do we have? And what have we learnt so far? What have been the challenges and the opportunities? So moving on to the first question.
Your attention please. Theatre sessions will restart in 5 minutes. Please make your way to the third session. Thank you.
Sorry about that. What area does South Devon and Torbay Clinical Commissioning Group? Hang on a minute. Slide issue. Oh, I'll just leave it at that. Cover. Well, South Devon and Torbay Clinical Commissioning Group was formed in January of this year after a merger of Torbay and South Devon Clinical Commissioning Groups, when we ran a process with the LMC to vote on what all the practices wanted to do. It covers 37 practices with a patient population of approximately 300,000. It commissions 100% of all the services from our acute provider, which is Torbay Hospital. Perhaps you have an image of South Devon and Torbay with lovely beaches and palm trees. In fact, Torbay is the most deprived local authority in the southwest. By 2020, almost 50% of our community will be aged 50 plus, compared with 40% nationally. There is a depressed economy with high relative unemployment, low wages and high child poverty. We have a higher proportion than average of people living with long-term conditions. If you are a man living in the least affluent area of Torbay, then you will die 8 years sooner than in the most affluent areas. The incidence of malignant melanoma in South Devon is one of the highest in the country. So moving on to question 2, what is our vision? Well, our vision is of patient-centred, joined-up clinical care. We want patients to experience no breakdown in communication between community care and the hospital, no unnecessary duplication of care, and no bouncing around the healthcare system. This vision of clinically joined-up care builds on the foundation of integrated health and social care that Torbay Care Trust implemented in 2005 and is being now successfully rolled out to South Devon. At that time, Torbay Care Trust agreed with Torbay Local Authority to pool the social care budget. This resulted in a decrease in the number of acute beds in the hospital from 750 to less than 500. The hospital has one of the lowest lengths of stay in the country. Physio waits have gone from 8 weeks to 48 hours. Occupational therapy waits have gone from 2 weeks to 2 days. Equipment waits have gone from 4 weeks to 4 hours. Back then, you were seen by several professionals. Now you are seen by just one. We want to improve this integration further by joining up clinical teams and business processes that enable management of the whole healthcare system. So what systems have we put in place to implement our vision? We started by reshaping our clinician-to-clinician groups, which historically have been principally a departmental meeting in the hospital with perhaps one GP involved. They've become unwieldy with up to 20 members. They work to no standardised terms of reference, no performance metrics. We reshaped them, halved the membership to 10, made sure there was an equal primary to secondary care voice, gave them standardised terms of reference, performance dashboards and quality dashboards. We now have 24 of these clinical pathway groups, with 47 GPs involved, lots of allied health professionals and patients. They generate lots of fresh, innovative ideas for new patient services. We also have for some time a local strategic forum where senior managers from local organisations sat. There was a few clinicians present, but it didn't feel very clinically focused. We decided to create a forum that was much more clinically led, a clinical cabinet which started in April 2011. Its membership includes senior clinical and managerial leaders from across the community and local authority representatives. It has evolved into becoming the senior strategic overarching group for healthcare for our local community. The clinical pathway group ideas are fed into the clinical cabinet, and the clinical cabinet has 4 overarching priorities which we've set up as task and finish groups. 1 are the clinical projects. 2 is making sure that the financial systems align so that we can do the right thing with patient services. 3, IT, information governance project scheme to look at having a single clinical care record for the whole community and hospital. And 4th, our communication group which is working on strategies to let everyone know what we're trying to achieve in the community. Here is an example of our newspaper, which is about to go out next week, and that is trying to let everyone know what we're doing, and it's the first time we've ever had a joined-up publication between the hospital, the community provider, the council, and us as a clinical commissioning group. We also connect the health and well-being priorities with the Cabinet. So moving on to question 4, what clinical examples demonstrate the effectiveness of joined-up care? There are several examples I could give, but I'm just going to briefly touch on diabetes, something the hospital have done that demonstrates joined-up care, stroke, and a follow-up tracker, which shows some thinking from one of our clinical pathway groups. So locally, with diabetes, there's been joined-up thinking between the community and the hospital clinicians for some time. This has resulted in decreased admissions to hospital, decreased amputation rates. And when you look at patients' HbA1cs, a marker of diabetic control, we have 58% of patients with excellent diabetic control, with HbA1cs of less than 7%. This is statistically significant when compared with other national comparable sites. However, there is still variability in diabetic care, particularly in primary care, and a rising number of patients with diabetes. We currently have about 16,000 patients, but anticipate this to rise to 20,000 within the next few years. We agreed at the Cabinet to make joined-up diabetic care a top priority. At the time, the lead diabetic consultant emailed me about how enthusiastic he was for the future of diabetic care. Here is a quote from his email. We partnered with Lilly, who provided details of diabetic care in primary care. The software identified themes and learning needs within practices, and then provided tailored education packages. We set up virtual clinics where the consultant dietitian, diabetic nurse visit practices regularly, discuss the audits, and help with problem patients. We've appointed nurses and dietitians to provide better community support, especially around insulin initiation. Here is a quote from one of our patients about Sam, one of our diabetic nurses. want to move on now to a short video clip, if I can get it to run, from the hospital, which shows joined-up working of internal teams within the hospital. I won't run the whole
This
thing.
is a story about how Torbay Hospital has improved the care for patients with hip fractures during 2010 and 2011. A project team was set up to plan the changes, aiming to improve pain control and reduce waiting time before surgery.
The average time that people would wait for an operation of this type would be 46 hours, and that has gone up and down a bit, but currently we're down to about 16 hours on average. And the length of stay similarly dropped from about 10 days down to about 6. We couldn't do this without the involvement of all of those people. That's absolutely critical. Even the people that are sometimes perceived to be quite low in the hierarchy, they are absolutely critical to making it work.
I found the whole experience very, very positive. Very positive in all respects. That is to say, the way the whole process of the treatment flowed from start to finish in that short time that I was here. How everything was attended to, the control of pain, the general care and being looked after and reassured, and it was a very, very positive process. I've got nothing but praise for the staff and their dedication,
So I'm just going to stop it there, but basically what they did was they had looked at the whole pathway and joined up all the staff along. They have a simulation suite at Torbay Hospital where they practiced it all and got all the relevant stakeholders involved and thought of all sorts of things that they hadn't thought of before. So the ambulance rings ahead, lets the A&E know that the person with the fractured hip is coming, somebody waits for them at the door, a coordinator stays with that patient throughout the journeys. There are problems with handovers and communications about social care at home, and everything is not lost as the patient goes through to the X-ray department and then is fast-tracked to theatre. And it really is a very impressive example of joined-up care within one system. And if you want to look at it fully, it's only a 7-minute clip and it's on YouTube. Okay, so moving on to stroke care. We were struggling to comply with NICE guidelines around the whole stroke pathway from primary to secondary care and back into the community. One of the problems was mobilising community teams to be able to effectively deliver early reablement for patients. There was a disconnect between the community and hospital teams. We have now appointed the hospital stroke consultant as honorary director of the whole pathway from primary care to secondary care and back into the community. All organisations have signed up to this, and it will allow him to direct community as well as hospital teams in the best interest of the patient. The benefits are efficiency, enable a patient-centred approach to care, facilitating the mobilisation of resources across organisations in a cooperative rather than competitive way. Safety, better governance, addressing safety issues associated with traditional primary, secondary care, organisational, clinical barriers. Equal access to care, flexibility in workforce across the whole pathway under a unified directorship, key solution in tackling the inequality of access we were getting in certain areas, quick productivity gains and length of stay, and data and information, easier to access all the data to inform decision making. So the final example comes from our urology clinical pathway group using an innovative piece of software called InflowFlex. They used joined-up thinking to see how they could tackle the number of follow-ups urology were having to deal with patients with prostate cancer. Prostate cancer is the most common cancer in men. Its natural history is long in most cases, resulting in hospital-based follow-up for many years. A sensitive PSA blood test tool is used to inform decision-making in the follow-up process. Patients attend follow-ups 3 to 6 monthly, and more often than not, there are no changes in their cancer care as a result. The Pathway Group adopted a piece of software, as I said, called InflowFlex, and they set up virtual clinics with a urology specialist nurse. She now virtually sees 60 to 90 patients instead of 20. Their PSA is monitored through the software that prompts them to have a PSA test when due. The new system is more reliable, easier to administer and to monitor. It creates much needed capacity for new patients. So far, this has created a cost saving of $182,000 for 600 patients, and more are being switched to the system. We're also beginning to look at the possibilities of using this software for haematology patients and other specialties. Prostate cancer patients continue to receive a high-quality follow-up service delivered by a specialist team while still in the comfort of their own homes. So what have we learned so far? What have been the challenges and the opportunities? Well, the key thing is to make the right thing to do the easiest thing to do, right thing for the patient. Build relationships across the whole system and think about how to make them sustainable. Have a clear vision and direction and communicate it well. Develop business processes such as financial systems, IT, that enable joined-up care. Our key challenge really is being clinical sustainability. How can we make sure that primary care provision is still maintained at a high standard while clinicians become involved in various commissioning decisions? The opportunities are exciting but simple. If you get it right, the patient has a higher quality, better experience of care. And if we just go back to that scene I talked to you about at the beginning, with the group of enthusiastic clinicians across the community and hospital, as well as senior managerial leaders and local authority representatives discussing robotic care and single clinical care records, was it a scene from the future? Well, actually, it was our clinical cabinet last week. And I've just got a very short WebEx. It was really good. And just want to say that the lady on the right is Paula Vasco-Knight, who's the Chief Executive of Torbay Hospital.
Fantastic meeting today. It was really good, particularly the advances in robotic surgery and what we're going to do with that. I mean, the fact that we've agreed now that ladies who've got gynae problems can go in and have minimally invasive robotic surgery is just fantastic development for our local community, isn't it?
Yes, and I particularly like the 24/7 University of Exeter modelling work that they did. That was really good.
I mean, what that means is that we're actually mapping the patient flow, making sure that patients can be cared for in the right place, that we've got enough capacity to deliver high quality, safe care right across the system. It's really, really good. What about the care record?
Yes, and it's great at last that we've got whole system agreement, having a single clinical record for the whole community as well as the hospital. It's going to be really great. Thank you.
Good morning everyone, my name is Claire Jones and I'm an Associate Director of Nursing in an integrated care organisation in Croydon. I joined Croydon in 2010 and like some of you, you may have read about the virtual ward, which is, Croydon was at the forefront of developing that service. If you have read about the development in Croydon, this is what it was basically. I'll keep going. Can you hear me better now? No? I feel like I'm shouting, so I'll just keep going. I'll raise my voice, and if it's got too loud, then wave at me again. So this slide shows how the virtual ward project was set up in Croydon in 2005 as a response to the National Service Framework for Long-Term Conditions. We introduced the role of a community matron for long-term conditions, and initially we had 2 community matrons, and as the project developed that morphed into 10 community matrons in 2008. The patients are identified via an algorithm which is the combined predictive tool. We're very fortunate that it's based entirely on Croydon data and demographics. And it's an evidence-based system that forecasts patients who will be using health resources. So basically the algorithm consists of information from GP records, A&E records, outpatient records and inpatient records. And although we weren't an integrated organisation at the time, that really benefited the project and how it moved forward. So the algorithm consists of 69 variables, of which there is an example there. It is predominantly how to identify patients that are going to use health resources in the local economy. There are, as I said, these 69 variables. Public Health collate all this information and they send it to the virtual ward every 3 months. The purpose of it is to identify what intervention would enable patients to have an improved quality of life, better disease control, hopefully to develop them so that they have a more healthy outlook to life. A lot of the work on the virtual ward is around establishing a relationship with the patients so that they actually self-care, so that they don't need to go to health resources as frequently as they were doing. So at the moment, the community matrons are seeing about the top 5 to 10% of the algorithm. So we have the virtual ward, which consists of the community matron. This is the interface with the other services that surround the virtual ward, and also to enable them to see these patients in a timely manner and to look at the cases and see where the pinch points are, what they can do to address the needs of that patient. They're supported by a ward administrator. Many of you who have read the Croydon data and how the project was set up, the information implies that we have a whole multidisciplinary team. In actual fact, that was never achieved. The virtual ward has developed by referring to other services, by using social services and developing those relationships. Unfortunately, the literature does give a slightly skewed picture of how the virtual ward has set up and developed. So as I said, we get the algorithm every 3 months. We then notify the patient and the GP. What we are doing now is an opt-out. We send a letter now that says you've been identified, therefore we're going to come and see you on this date. Please supply the medical summary from the GP surgery or identify to us any reason why they shouldn't be seen on the virtual ward. Previously we had a lengthy process asking for permission and it just took too long. Patients were being admitted before we could even see them. So we've put up a case study of a typical virtual ward patient. He was originally identified on the algorithm with a risk score of 95.5, CA prostate, diabetic, Parkinson's disease, quite a typical patient for Croydon, which is the largest London borough and has high areas of deprivation and very high incidence of diabetes. At that point, when they were identified by the algorithm, the DM was visiting once a week to change the catheter bag. He had attended A&E 18 times. He hadn't turned up for appointments 13 times, and he very rarely, if ever, went to the GP surgery. So he was identified for the algorithm and was started to be seen by the community matrons. They worked on a care plan with the patient. He was then accompanied either by a community matron or if we could find, we have generic support workers also in our community services, and they would go with him and support him at appointments. Coloured posters were put in his flat to remind him about things that he needed to do. The GP, after a case conference, agreed to visit him at home. He gained weight, and generally, with everything that was put in place, his risk score came down to 86.3. Now, from 95.5 to 86.3 is not a huge difference. However, we're dealing with patients who have multiple comorbidities. They're extremely complex, and they are the real high users of health resources. As I said, in 2008 we were up to 10 community matrons. I think you'll all agree the local health economy and the national health economy has slightly changed. We've needed to identify cost savings and redesign the service. Currently we have 6 community matrons supported by 3 administrators. We still have the referrals from the algorithm, but what we have done is worked with our local GPs to encourage them to refer directly, and they use an amalgam of the Castlefields criteria, which some of you may know. And in actual fact, we found that taking direct GP referrals actually stops a lot of patients even getting to the algorithm and being identified. GPs know their patients well and know how they would benefit from the service. We're now an integrated organisation, so that's the acute, which is Croydon University Hospital, and the community services joined together. So what we're working on now is developing patient pathways across primary and secondary care, similar to how Sam just described in Torbay. This enables earlier discharge, and what is key to that is the consultant that has led that package of care in the acute unit retains clinical responsibility for them in the community if the GP feels that they do not have the skill set to deal with that complexity. We also are developing an acute geriatric assessment unit led by our lead geriatrician, and that will enable GPs to refer in when they feel, again, that they're not quite sure what's going on with these complex patients. They may not need an admission, but they can come in. What we need to do is further development of hospital avoidance work with our local CCGs, and we're also a pilot site for 111, which is the number that you phone if it's not an emergency. So that really links in with our services. With the 6 community matrons, we've also put them in with the community nursing clusters in Croydon, so that if they need a different skill set of nurses, they can use the healthcare assistants, the staff nurses, or the district nurses. Evaluations of the service, as I said, it's written up in much of the literature, and to be honest, we've evolved from how that's been written. We've changed the service, and how we evaluate that is patient experience surveys. We have the predictive tool, which is the algorithm, versus actual admission rates. There is a large-scale Nuffield study led by Geraint Lewis, who will hopefully be reporting any time now. He's evaluated Croydon, Wandsworth and Devon, I believe. So that will be really interesting and will help us to develop the service in different ways. Our challenges are data collection. Even though we're an integrated organisation, the IT systems don't always talk to each other. They certainly don't talk to GP systems. The algorithm is retrospective. It's, have you been admitted to A&E already? Have you gone to MAU? Have you gone to your GP surgery? We're trying to get ahead of the curve, and that's quite a difficult thing to do, but it's definitely being facilitated by patients who are well known to their GPs. Clarity of outcome measures. The virtual ward was set up with slightly unclear outcome measures, which we need to work with our GP colleagues, our commissioners, to try and change them, because it's actually skewing the service in a way that isn't particularly productive for either the service givers or the patients. So the success of the virtual ward in Croydon, the average reduction in A&E attendance has been about 8%. The reduction of thereon an admission rate via A&E has been 5%, and there is a greater awareness of the alternatives to admission. Frequently, a patient who is very complex will turn up at A&E. They may meet a fairly junior doctor who then thinks, actually, community services can't cope with this. Well, they can. There just needs to be better communication. So now we need to do yet another service redesign, and we need to do that in line with the outcomes of the Nuffield evaluation, our very drastically altered financial circumstances, and to work towards the agreed outcomes with our local CCGs.
Great, thank you very much, Claire. Sam, do you want to come and join us up on the stage? A chance to answer some questions. Have we got anybody that would like to ask a question? Just pop your hand up. The microphone's coming down the front right now. In the meantime, I guess as a commissioner, I'm really keen to understand not only the benefit I might deliver and it being less expensive, but if I'm then able to extract that resource from a traditional provider to reinvest it in other services. So I guess just a quick question from the both of you. Has this led to a downsizing in acute services, a disinvestment in acute services and reinvestment elsewhere?
From the point of view of our diabetes model I've talked about, yes, it's the consultant that's involved in that is going to be spending or is spending much less time in outpatients, so the outpatient model is shrinking. From the point of view of the PSA tracker one I mentioned, what that's allowing is the outpatient time for follow-ups to shrink so that they can get to their backlog on new weights, which is actually being quite long. Mm-hmm. Yeah.
And Claire, any?
From our point of view, I think it's enabling earlier discharge from the acute. Invariably, it would seem our very complex patients, once they do get admitted, it's persuading our acute colleagues to actually let the patient go home because there is a support service. And that, with a developing relationship, is a lot easier to do.
And those of you who were in the first session might remember that I am the key relationship, patient-centred healthcare. Question in the front. Let us know who you are, where you're from. First question.
John Orwell, GP from Weymouth, so similar demographics to Torquay, but a nicer beach. So my question's about IT. My question's about IT. I noticed Croydon has a problem with its IT. Torquay, you seem to be moving towards a solution. Could you fill us in on some of the technical details? Thanks.
Right. Well, I'm not sure I'm going to be able to give you much of the technical details because I'm not sitting in that task and finish group, and the guys that are seem to be moving on with it quite well. They're looking at bolt-on software for the different systems. Our GP systems in our area, we've got about 5 different systems that the GPs are on. We have had the debate about whether everyone should switch to one system. Certainly, having talked to the GP IT lead in Cumbria, he thinks that is the simplest solution, and he would recommend EMIS to do that. But we think that probably politically will be too tricky. So we're looking at this bolt-on software that enables everybody to see each other's systems. So that's the route we're going. We're involved in a tender bid with that at the moment. But I can't tell you much more than that about it.
No, makes sense. In Weymouth, we were a pilot site nationally for looking at that. We tried moving one system and then we tried the bolt-on underneath. The bolt-on underneath works much better.
Oh, good.
Leave everyone with their system and just integrate behind the scenes.
Yeah.
I think integration of information systems around the eye, the patient, seems to be a really key challenge for all of us. If anybody's got anything they'd like to contribute to that debate, pop your hand up and we'll hear what you're doing rather than if you haven't got a question. We were listening earlier about Simulate, a simulation tool to allow you, and in fact they use PSA testing as a really good example of reducing weights in an acute outpatients. So I'm just keen to to understand how you got from here's a great idea to do something. You talked about simulating it by actually getting the providers to run it. How did you get from this is a good idea to actually that sort of practical simulation?
Well, there's 2 different things. So talking about the simulation they did for the fracture neck femur pathway, they're using that for lots of things. They've got a whole simulation suite in the education centre at Torbay Hospital, and they have a dedicated innovation team that work behind that. And basically, when somebody has a good idea about how they might improve the pathway. They get everybody that might be involved in that pathway along. So for the fracture neck of femur one, they had the ambulance crew there, they had a patient along, and they had all the different nursing teams, from the kind of A&E based teams to the theatre based teams, and then they run, and it's all done in a very apparently frank and open way, so that no one can feel embarrassed to admit that they, you know, X might not be going as well as it could be, and then they run through every single tiny step of the detail, and that's where they work out where the blocks are and where things could be streamlined better. But from the point of view of the PSA tool, actually I've got one of our senior managers in the audience, Lynn, who could tell you about how when the urology pathway group first talked about the PSA tracker, there was quite a lot of resistance actually to thinking about adopt that model. So if you just want to say a little bit, Lynn.
First of all, when you're innovative, you look around and see who's got a bigger and better idea. And I have to say, if Bath are here, they'd already done it, so that helped us develop a tracker. And so we took the idea from Bath, but our acute unit already were using Infoflex, which is a Microsoft product, and you can bespoke that product to work in any way you wish. So we use that with our cyber lab to connect the blood result to Infoflex, and we embedded the blood form and the standard letter to patients. Then we identified the cohort, and all of the patients were written to with an explanation of what we were trying to do, and we were overwhelmed by the response of patients that wanted to go on to tracker because they didn't actually value the follow-up at the hospital simply to get a blood test result. So that went really, really well, and we did that within the clinical pathway group. So we audited some of the pathways, and then we set up the system locally, wrote out to all our GP practices, and the big key thing for them was making sure that the blood result didn't go back into their inbox and they felt they had to do something about it. So we put a flag on it that it's a tracker patient, no more work for primary care. It's taken 2,500 follow-ups out of the system, and great response from the men who have that care. And it happened very quickly and very easily, and we're all shocked by how well that went.
Yeah, question down the front here, and then one at the back, or in the middle.
Andy Czerski, GP lead in Reading. We've got a system in Reading called Dawn system for tracking our rheumatology patients. It's a similar sort of thing where they track the results. We don't have to actually act on them. And if a patient has abnormal results, the rheumatology nurse contacts the patients, and then if they need flare response, they get called up to the flare clinic. Just another way of monitoring results without the GPs feeling they have to do something about it if they know they're on the Dawn system. When we get the results, it shows it's a Dawn patient, and the software picks up the abnormal results.
Yeah. Pop your hand up again, and we'll bring the mic to you.
Hi, Hazel Carter, GP in Yorkshire, Calderdale. I just want to ask again about the integrated care for the intermediate tier sort of patient. When you have a virtual ward and you have a consultant responsible for people who the GPs weren't yet ready to take over, what happens out of hours?
We have an out-and-out service, Patient Care 24. We also have 111. What we can do is feed into our MAU consultants as well, because we've developed those links. So the matrons attend MAU every weekday anyway, to try and filter any of their patients.
So ordinary hours like 8 till 5, you could get to the consultant, and after that, MAU consultant, right?
Yeah, if they come into any difficulties, if they're supposed to fill out a fax form which goes into our MAU consultant on a Friday if they think there's going to be any problems, so that he's aware of what's been going on.
Thank you. Any idea how many patients you look after for the number you said that of community matrons that you've got?
You know, this is where we got into some difficulties with our outcome measures.
Okay.
Originally, we had 10 community matrons, and one of the outcome measures set by the PCT was a minimum of 500 patients on the ward, which obviously equates to 50 patients per matron. Because of cost savings, we've had to bring that down, but that outcome measure is still in place. So we're working with our commissioners to make a more meaningful set of outcome measures.
But what sort of caseload have you got for your matrons at the moment then? What caseload are they running at the moment?
That we're still working them towards the minimum of 500 patients.
Right, thank you.
So what it's done is increase that patient's length of stay. It's a disincentive to discharge them from the ward. We're very honest with our commissioners as to, it's the wrong measure.
So one final question.
Angus Slingy, GP from Newbury CCG. Could I ask, Sam, you said in Torbay there 47 GPs involved, what did you say? What was the hook and what was the solution to the work back at the practices, to cope with their absence?
Go on, keep going.
I think trying to think really what the hook was. I think it wasn't overnight. It built. I think reshaping the clinical pathway groups into much better forums where people felt actually real decisions were being made and it was effective. It wasn't just a sort of group of people sitting around having a chat. It was really systematised. Really helped. Lynn was instrumental in helping set all that up and actually has set up training for the GPs and the consultants, so they all go through different bands of training depending on what level they're sitting on within the commissioning groups. I think giving them bespoke, tailored training they've really enjoyed because they understand the metrics and everything now much better, so they feel confident speaking. So it grew and grew, and then we ended up with a waiting list. So actually we've had a bit of a problem in that we've got almost an over-enthusiasm now of clinicians wanting to be involved, so it does create a problem with clinical sustainability. And what we're doing to address that is we've just literally advertised nationally, and I think we may have just appointed this week, a dedicated GP to our commissioning group. And this is the first of our idea is to actually have a bank of GPs that are actually employed as salary to our commissioning group that do part commissioning work but also do backfill in practices. And the idea is that they, when they are doing backfill in practices, they act as a partner would. So we're changing kind of the job description to make sure they understand all the extra implications of sitting in a practice and looking for quite high quality people. And that's been quite appealing to people. We're also working with the deanery, the Southwest Deanery, to look at newly trained GPs literally just passing their FT4 bit, and basically we've already had one of those who was really good, and looking at whether we can do some kind of 3-year package with those new GPs where again we give them some commissioning experience and in return they do high quality clinical backfill for us.
Lots of nodding going on in the room there. Sounds like there's another stream there in terms of how we actually create the capacity to get the job done. There is the opportunity obviously for you to network around that, but please just join me in just thanking Claire and Sam for their presentations.